Hello and welcome to the inaugural TAPS Journal Club, which is aiming to educate and stimulate discussion on all things pleural and highlight both the big papers that are being published and also smaller local research that's ongoing in a lot of our centres. I'll be chairing today's session. My name is Deirdre Fitzgerald and I'm a respiratory and pleural physician in Tala Hospital in Dublin, Ireland. And I'm delighted to be chairing with my colleague, Dr. Sonia Cherian, who is a respiratory and sleep physician at Auckland City Hospital. Today, our first speaker is Arash Badiei, who is a respiratory physician and interventional pulmonologist. He serves as pleural lead and interventional pulmonologist at Royal Adelaide Hospital and holds a clinical associate professor appointment at Adelaide University. He holds leadership roles within TSANS and is a strong advocate for interventional pulmonology and pleural medicine. And internationally, he is co-president of the World Congress of Bronchology and Interventional Pulmonology 2026, which will be hosted in Oceania for the first time in December this year. So I'm going to let Arash take over now, and he is going to discuss the SCOPE trial.
Thank you very much, Deirdre. So hopefully that's sharing. Thank you so much for asking us to be part of the first journal club for TAPS. It's a big honour. So I'll be presenting this study by Professor Porcel and colleagues from Spain, which was published in the European Respiratory Journal this year, titled Saline Lavage Alone Prolongs Drainage Compared with Intrapleural Enzyme Therapy and Pleural Infection, the SCOPE trial. So why is this important? Well, we all know pneumonic effusions and empyema, collectively pleural infection, are common. We know pleural infection also can develop in the absence of pneumonia. The standard of care at the moment is with the use of antibiotics plus drainage, and in appropriate cases, we add intrapleural enzyme therapy, which is a fibrinolytic and mucolytic agent, typically TPA and DNase. Saline has been used, but saline's role is unproven. So intrapleural irrigation is used in certain situations, but the evidence is weak, with only one small prior RCT, which is the PIT trial, which some of you would be familiar with. So one of the criticisms of the PIT trial is that it's got an out-of-date comparator. So the PIT compared saline against tube drainage alone and didn't control or have IET or the intrapleural enzyme therapy as the standard of care, which it is now. So the evidence gap really there is that there's no trial which has asked whether saline, either alone or added to IET, offers anything beyond intrapleural enzyme therapy alone. So that's what SCOPE was designed to try and address. So basically, they were looking at adult patients with pleural infection, which is defined as complicated pneumonic effusions or empyema. And the question is intrapleural saline lavage, either alone or added to intrapleural enzyme therapy, superior to IET alone? So the population, as is in their question, is adults with complex pneumonic effusion empyema requiring chest drainage. The intervention they're looking at specifically is saline lavage, with intrapleural enzyme therapy. And it's important for us to note that they used urokinase and DNase in this study. And as a exploratory arm, they also had a saline lavage only group. And it's important to, again, just highlight at this point that this arm was only an exploratory arm. So the comparator was what is standard of care, and that's intrapleural enzyme therapy, again, with urokinase alone. And their primary outcome was days with chest tube in, so the duration of drainage. So this was a prospective randomized superiority trial that was performed in 2 Spanish centers. Groups were randomized by computer-generated block randomization in a 1-to-1-to-1 fashion, and the analysis principle was an intention to treat. So I think design strengths definitely at the start and outset is that it's prospective and it was registered. The funding source is public, so there doesn't seem to be any bias from any pharmaceutical or device companies. There was a pre-specified statistical analysis plan that aligned with the protocol, and importantly, there was an active comparator, which is the intrapleural enzyme therapy as compared to PIT. So again, I just want to highlight that the pre-specified primary comparison groups of the study were actually saline plus intrapleural enzyme therapy versus intrapleural enzyme therapy alone. And that will become a bit more important as we discuss some of the limitations and I guess some of the criticisms of this trial. And the saline only arm was the exploratory comparator. So inclusions, the usual in these types of studies, so we're talking adult patients that were referred because of suspected pleural infection, which they defined as the usual set of clinical plus pleural fluid results. Their exclusion criteria, again, nothing surprising. So allergies, short life expectancy, and if there was another cause for the effusion. In terms of follow-up and outcomes, they collected data at days 2, 5, 30, and 90 days. The primary outcome, as we've discussed, was duration of pleural drainage. So that's the number of days from randomization to tube removal. And the secondary outcomes were radiographic reduction in pleural effusion size on days 2 and 5, the need for additional chest tube placement or surgery, length of hospital stay, and then mortality at 90 days. So this is the consort diagram. So they assessed just over 250 patients for eligibility. Of those, 162 were excluded. Interestingly, when you look through this group, the usual group are there, but you can see 24 were treated by an unblinded team. And this might be because these were patients that presented out of hours or patients that may have been sicker. So I guess maybe something to consider in terms of generalizability of this trial. But of the ones that were randomized, 91 was excluded due to a diagnosis of TB pleuritis. So that left basically 30 in the lavage group, saline lavage group, another 30 in the saline lavage plus intrapleural enzyme therapy group, and then finally the standard of care kind of arm was 29. So in terms of the overall group characteristics, so the median age was 62. There was a male predominance. By far, the majority of the infections were community-acquired. Empyema in about 33% of patients. The majority only needed a small chest tube, being defined as less than 14 French. And then on average across the three groups, the duration of antibiotics was about 3 weeks. And again, across all three arms, the amount of drainage was around 1 litre. So this slide is a bit busy, I apologize, but it's just to kind of drill home the actual treatment or intervention that happened. So all patients had, after chest drain insertion, their fluid was aspirated to a maximum volume that the patient could tolerate. Or till dryness. And I know that this isn't standard of care across all institutions. For example, at our centre, we wouldn't drain to dry straight after chest tube insertion. So I think, again, this is something that we need to consider. In the saline lavage only group, so the procedure was basically to instill saline and then immediately aspirate and repeat that cycle until the fluid turned clear. In the saline lavage plus intrapleural enzyme therapy group, the same thing happened with the saline lavage first, and then after that, urokinase 100,000 units plus DNase 10 milligrams was given concurrently, and then clamped with a dwell time of 1.5 hours before drainage. And then in the IET alone group, which is the standard of care, urokinase 100,000 units plus DNase 10 milligrams was again administered concurrently once daily, and this was the standard of care. So the two treatment or the primary comparison was actually between this group and this group. And then chest tube removal, that was decided by a blinded investigator who they defined as a senior pleural specialist in one of the units. And they had basically three predefined criteria. So one was of minimal residual effusion on ultrasound, clinical stability, being resolution of fevers, and following inflammatory markers. So this is basically their result. So when we look at the primary comparison group, so saline plus IET versus IET alone, there was actually no significant difference between those groups. The significant difference came from the saline lavage only group, being on average or a median of one day longer, so 4 days compared to 3 days in the other groups. So the primary comparison that mattered was the saline plus IET versus IET group. There was no significant difference. And the only significant difference was actually in the group that was the comparator, the exploratory arm, that was saline only. So in terms of secondary outcomes, so mostly no differences and some underpowered signals. So in terms of the second day radiography in all arms, there was no difference. By day 5, the intrapleural enzyme therapy seemed to show better resolution of radiographic opacity. The addition for chest drain, additional chest tube or surgery was not different among the groups, but you can see there is a trend towards the saline group actually having more, but none of these were significantly different across the groups. Length of stay was also not significantly different. 3-month mortality was not different. And overall, the adverse events in the smallish groups was only one rare event of hemothorax, which happened in the saline plus intrapleural enzyme group. So when you look at it, so every patient-centered outcome, being surgery length of stay, mortality, actually was either not significant or underpowered to detect anything. So, and they didn't have any quality of life or functional endpoints in this particular study. So this is where I think my main criticism comes from, and I have to stress this, that I think these trials are very, very important to do, and this is a hard study to do. So it's not a criticism in that sense, and I think we should commend the authors for doing this study because they're not easy to do. But I think there is a bit of a discrepancy between the way that the headline is framed compared to what the actual study was designed to look at. So what the trial was designed to test was whether saline plus IT is superior to IT alone, and that result was negative. So at best, all we can say is that saline plus IT is not superior to IT alone. But what is appeared on the paper and the way it's framed is that the exploratory comparison arm, that saline alone prolongs drainage, because that result was significantly different from the other two groups. So when we drill down into this a little bit more and look at the patient characteristics, and this is because this is a relatively small number per group, and just by pure chance, the group that was the standard of care arm, so the IT group, you can see that this group, 82.5%, either had a low to moderate rapid score, meaning that they were probably less comorbid, they were probably fitter patients, and by definition, they had a lower the 3-month mortality and probably required shorter drainage, whereas the saline lavage only group probably numerically had the more sicker patients. This group also, just numerically by chance, had the larger volume of pleural effusion on X-ray. They corrected for this in one of their outcomes, but not for the primary comparator. So again, so I think this is just an unfortunate imbalance against the saline alone only group because they only had small numbers. But when we look through the characteristics, you can see that saline only group had the highest percentage in terms of the size of the effusion. The pleural glucose was the lowest, the rapid score was the highest, and diabetes also reflected in the rapid score. And they also had the most non-infectious deaths. So this is a sicker cohort when you're looking across the three groups. Now they did, in terms of the radiographic outcomes, adjust for the baseline effusion size. But as I mentioned, they didn't do this for the primary endpoint, which was uncorrected. So just in terms of an overall view, in terms of my thoughts on the limitation, underpowered for non-inferiority. This was a superiority trial, so we can't talk about inferiority. So saline plus IT is not, we can't say that it was inferior. All we can say is that it wasn't superior in this trial. There is subjectivity in terms of the saline lavage. So what the protocol required was that saline was infused and aspirated, and that was repeated until it was clear. But there wasn't an objective way to define what clear meant. So it was up to the operator or the investigator to determine when that fluid was clear. And this obviously produces issues with reproducibility. There was no patient-centered outcomes. The IT protocol, urokinase plus DNase, was not the MIS2 protocol. So this is, again, not generalizable to a lot of the centers that use the MIS2 protocol, which is to date the RCT-based evidence standard of care that we use. So urokinase plus DNase concurrently once daily was not the same protocol as MIS2. The saline protocol that they used was also bespoke. It wasn't the same as the PIT protocol. So the once daily installation and aspiration till clear was very different from the PIT protocol, which was 250 mils of saline instilled 3 times a day for up to nine installations. And then and I think this last one is, is a criticism of all of these trials. These are hard to do as to how you define an endpoint of when the chest tube should be removed. Although they did set some boundaries in terms of things that are required, it was still subjective based on the pleural expert in that center to decide where the effusion was in terms of ultrasound, how clinically improved the patient was, and how improved the inflammatory markers were before deciding to pull the chest tube out. But like I said, I think these trials are really important to do, and I think we should commend the authors for doing this trial because they're hard trials to do. So I think some of the credit where it's due is that this is a first of its kind. It's the first RCT to test all 3 intrapleural strategies against a comparative, a contemporary comparator, which is the IT therapy. They did have a pre-specified statistical analysis plan and a registered protocol. They were very transparent about the limitations of this study in their discussions. There was an attempt, even though this was a criticism of mine, but there was an attempt to try and have a rigorous adjudication in terms of chest drain removal. But this is a limitation of a lot of these trials, I think, as to how do you objectively decide when a chest tube should be removed. And then the urokinase comment. So the urokinase, so the fact that this is, I think, to the best of my knowledge, is actually the first RCT to use urokinase plus DNase in pleural infection is important because it does show that it does have efficacy. And we need trials like this. So I think that is a big credit to this particular study. So overall, my interpretation is that saline lavage alone is not superior to IET, and there's no signal to add saline on top of what is already optimized ultrasound-guided chest drain insertion and daily reassessed intrapleural enzyme therapy. But the caveat to that is that the no benefit of adding saline rests on a null superiority trial, and it's really too small to exclude real differences. So the thing that we don't know is that saline may still have a role in those who have contraindications to IET. And that brings me to the end. So I'm going to stop sharing here.
Thanks, Arash. That was really nicely presented. I agree, a really interesting question to study. I guess intuitively, in my mind, I would have thought that the addition of saline to fibrinolytics may not have had an added benefit. Just thinking about fibrinolytics, how they work, breaking down loculations and having a bit of an auto-lavage effect. And then the DNA is reducing the viscosity. What do you think about that?
Yeah, I think I agree. I think if you have a heavily loculated effusion, that kind of thinking makes a lot of sense, because why would the saline be able to get into loculations? So I guess the one aspect might be that just the mechanical debridement of the locules might be an element. So the fact that you're instilling something with force, that fluid may open up locules, allow some communication between locules. So I guess that's one thought. And then the other is, we tend to use TPA DNAs in not heavily loculated effusions as well when the clinical suspicion is there, the fluid isn't draining well. So just the mechanical movement of, infected debris, inflammatory debris in the pleural space, and what additional benefit that brings, I think is the key of what they're trying to explore and explain. And I think that the role of saline probably is in those that don't have, or that have contraindications to IET therapy. I think we've pretty conclusively shown that IET therapy works and is effective, at least at, reducing the need to go to surgery, improving chest x-rays. We still don't have, much in terms of mortality data in terms of its benefit. But in terms of those, reducing the need to go to surgery, I think the evidence is there. So I think what this study hopefully adds a little bit to is that, in those situations where you have a contraindication to IET therapy, can we use saline lavage? And I think, we can, because this was, again, not a non-inferiority trial, but it just isn't superior to IET therapy. Yeah.
It'd also be interesting to know what the different subgroups look like in terms of how complex or loculated effusions were, whether less loculated or we don't. Yeah.
So hopefully they've got the data there to do maybe a secondary analysis and release that in a second paper, because it would be interesting, I think. That would be a really interesting question, because it might be that just by default, the saline group may have ended up with the more complex loculated effusions, and this is why it wasn't effective.
And then going back to your point, I just noticed the CRPs were not as high as I'm used to seeing. I think they were around 100. Whereas I'm usually dealing with empyemas, CRPs 300, 200, which that group, thought that was an interesting point.
Yeah, and it could be that 24 that they excluded may have been a sicker group that we didn't see. So this was obviously, and this happens in trials, and this is what I mean by these trials are hard to do. Because, a patient comes in at 3 o'clock in the morning to the emergency department. It's really hard to randomize them into a trial like this. They may be the sicker ones that we're just not capturing in these trials. And so I think the study was, it's pragmatic. It's recruiting the people that are recruited for these trials, but may not reflect true clinical practice with that high exclusion.
And also just even thinking about how the pleural drainages were done, they're done with pleural experts vacuum aspiration, which I don't do, and daily dosing rather than BD. And I guess the generalizability of doing that on a ward where you're not doing a ward round every day may also explain how the length of stay was a lot shorter than I would expect in general.
I agree with all that.
Their chest drain duration was pretty short, right? 3 days versus 4 days.
Absolutely,
shorter than my typical.
We're looking at a 1 day difference, and we're doing a once daily assessment. So the resolution of your chest drain kind of removal is 1 day. So you're right at the limit of the resolution of your actual outcome. So I think, we have to take that into account. So
All right. Thank you so much.
Sorry, I was just going to say it's important to publish negative trials as well.
Absolutely. Yeah.
We're all looking for positive results. So I just thought it was really good that it was, that we're not focused so much on just the positive ones that we.
Yeah. And I think there's a lot of positives to take away from this trial. So again, I can commend them for doing this trial. And I think it was very well run despite these trials being very difficult. And hopefully we all learn, and the next trial will add on top of this.
Thank you.
Thank you.
Thanks for that.
I'm going to hand over to Michael now. So we're going to swap seats.
All right. So I'd like to introduce Dr. Michael Brown. He's a consultant respiratory physician at the Royal Adelaide Hospital with expertise in interventional pulmonology and lung cancer. He's undertaken advanced procedural and research fellowships at the BC Cancer Vancouver General Hospital in Canada, where he contributed to the National Lung Cancer Screening and Early Lung Cancer Detection Research. He's currently completing a PhD focusing on improving diagnostic and predictive tools for lung cancer, including functional imaging.
Thank you very much for the introduction. And as Arash has already said, it's a real pleasure to be able to log in today and to join all of you and to present this trial. The trial that I'm presenting today is some of the work that we are doing locally at the Royal Adelaide Hospital and published relatively recently. It's a small retrospective audit, but we thought it was interesting to share because the technique that I will speak about in a moment is one that is becoming part of our routine practice. And it's not something that has been published frequently in the literature. And so we thought we would share it with you today. The purpose of this trial is really to look at the feasibility and safety of a combined technique as the initial upfront procedure for the diagnosis and therapeutic management of patients with a high pre-procedural probability of malignant pleural effusion. So specifically, we're combining diagnostic thoracocentesis, ultrasound-guided pleural biopsy, and IPC upfront. A little bit of background very briefly. Malignant pleural effusion is a common problem, a particularly big problem for Australia. The global incidence is 70 per 100,000 per year. It's associated with poorer outcomes for patients. There's more than 8,000 Australians diagnosed every year. And interestingly, in particular, mesothelioma is something that is overrepresented in Australia and very common in South Australia. We had 240 cases in 2024 alone, which is a significant number and really represents its use in the building industry for us. As many of the viewing audience would know as well, often pleural fluid cytology is not enough to diagnose malignant effusion. The diagnostic cytological yield ranges from 40 to 87%. The major factor that probably influences that is the type of cancer that is being detected. Mesothelioma in particular has a very modest pleural fluid cytological yield. And so that was part of the impetus for us combining some diagnostic techniques. In terms of other diagnostic techniques, there are multiple available: closed pleural biopsy, ultrasound-guided biopsy, CT-guided biopsy, pleuroscopy, and VATS that have steadily increasing sensitivity and specificity. The main reason for us choosing ultrasound and guided biopsy as part of our diagnostic and therapeutic pathway is because it's a physician-led procedure with no requirement for radiologists or surgeons to do the procedure, so we can do it ourselves. There are some very well-established guidelines, as all of you would know, for the management of malignant pleural effusion, the most recent being the British Thoracic Society guidelines from 2023. Within that, this is a well-recognised workflow for the management of pleural effusion. And what it takes is usually a confirmed malignant effusion, which is diagnosed through a stepwise series of pleural fluid sampling and biopsy, and then once establishing the diagnosis, consideration to definitive management. And so by us combining thoracocentesis, ultrasound biopsy, and IPC up front, we are really just amalgamating what is already existing evidence into one procedure for our patients. And so the goals, as you would all be aware, is for symptom control, quality of life, complete fluid control, and to reduce hospital interactions. And so we've kind of approached our patients with those in mind. So onto the study. So this is a retrospective review, really looking at safety and feasibility. We retrospectively looked at all pleural patients that received pleural intervention between March 1st, 2021 and September 30th, 2022. So the first 18 months of offering a combined procedure. And then we looked more closely at the subset, the 16 patients that had the combined procedure. We really included all patients who received that combined procedure, and there was no external funding. This was investigator-led. And we don't have any other conflicts of interest. So as mentioned, our patient selection being a retrospective trial and really just being an audit of our work, we did not control for patient selection, which represents a major limitation and a bias of this study. So we had 16 patients that had the triple approach. The kinds of patients that we were selecting, again, not controlled, but is patients who have suspected malignancy, either an active or past malignancy history of high asbestos exposure, and then a low likelihood of an alternative explanation, pleural infection, heart failure, liver cirrhosis. We also paid close attention to radiological features of suspected malignancies, so patients with definitive pleural thickening on the CT or the ultrasound, diaphragmatic thickening, diaphragmatic nodules, and in cases where there was a PET avidity. A few notes on the actual procedure that we performed itself. Every patient had standard pre-procedural bloods. We performed the procedure with the patient in a lateral decubitus position with the diseased side to the roof. All patients received pleural ultrasound and then light sedation with continuous vital sign monitoring. We performed topicalization to local injection of lignocaine to the level of the pleura, took a 20 ml syringe aspirate for biochemistry, and then used the Temno 16 or 18 gauge needles from Mediologic for pleural biopsy. We did that under ultrasound guidance, and then inserted a Rocket 16 French IPC. As is routine practice for our centre, we admitted all patients to the ward overnight afterwards, and after that they were discharged for home nursing follow-up. So just to give some insight into how we came to acquire these 16 patients. So they presented through a variety of methods. Through the emergency department was the most common, 10 out of 16, but also from rural and outpatient areas. All of the patients were either seen by interventional pulmonologists like myself and Arash in the outpatient setting or the inpatient setting. If they were eligible and had a high pre-test probability for malignancy, we considered them for the combined procedure. If not, then our pleural patients just receive standard of care as per the guidelines. Post the procedure, all patients were admitted for 24 hours, after which, if the results were diagnostic, and I'll go through that in a moment, then they went on to the multidisciplinary team meeting for further management. If they were non-diagnostic, they proceeded to an alternative diagnostic pathway. And then we looked at the time to first interaction with medical oncology, radiation oncology, or palliative care. All 16 patients were linked into an ambulatory home service with home nursing. So these 16 patients, just to highlight where they fit in within the general landscape of our pleural medicine at the Royal Adelaide. So what I've captured here is all our pleural procedures and types of procedures that we did in our procedural suite over that 18-month period. So it's excluding patients that had potentially drains or taps on the ward. But we try and do the majority of our procedures in the suite. So 25% of our patients underwent multiple procedures spread out over weeks or months. but the majority is still just receiving a single procedure, and the 16 patients are captured within this single procedure part of the pie chart. The pie chart on the right shows the types of procedures that we generally do. So we don't do a lot of pleuroscopy. We do quite a lot of closed pleural biopsy, so that's ultrasound-guided pleural biopsy, lots of IPCs and lots of intercostal catheters. And I've just put a little asterisk here next to thoracocentesis only. So if patients had an IPC or an intercostal catheter, that wasn't counted in the thoracocentesis only statistic. This was purely patients that just received a diagnostic or a therapeutic TAP. So 16 patients, I don't think is particularly surprising. They were a slight male predominance. Mean age was relatively advanced, 77 years old. ECOG functional status 0 to 1 predominantly. Slight predominance of right effusions. Most patients either had a smoking history, 50% had an asbestos exposure history, and 7 had a prior malignancy history, so selecting for those kinds of patients. And the CT scan characteristics were very much in keeping with high pretest probability of cancer, so lots of nodularity and or pleural thickening and significantly large effusions that made us think that they were high risk of recurrence. On the left there is the diagnoses that we made during our time. So all 16 patients had malignancy diagnosed, and there was a range, quite a large number of mesotheliomas, so 7 mesotheliomas in that group, and 4 primary lung adenocarcinomas with a mixture of other malignancies. This slide here just shows the diagnostic yield breakdown between the thoracocentesis, so the fluid, versus the biopsy. Interesting data. So 15 out of 16 of our thoracocentesis group had exudative effusions, with 1 having a transudate. Cytology was diagnostic in only 18.83 cases, so not many. Atypia present in 5, and cytology was negative in 8 out of 16, which probably reflects a high mesothelioma predominance within our small cohort. Pleural biopsy, conversely, was very much diagnostic, 81% of the cases, 13 out of 16. Atypia was present in 2. Histology was negative on 1 occurrence. And when ancillary studies were required for the primary malignancy, it was adequate in all cases. And so again, this likely reflects bias of patient selection in our group and a high rate of mesotheliomas. We did also retrospectively look at the time to medical oncology and radiation oncology interactions, just to get a sense for how our workflow was affected. So, and again, this likely reflects the fact that a lot of our patients came through the inpatient pathway or came through the emergency department. So our time to being seen by an interventional pulmonologist was short, mean 3.2 days or median 2 days. The time to actually having a tissue diagnosis had a mean of 9.3 and a median of 6 days, so relatively quick. And then it took about 1 month for the time to first medical oncology and radiation oncology interactions, usually in the outpatient clinic. And so there's not a lot of comparative literature because, as I mentioned at the start, there's not very many trials that look at this combined technique. But I've included one study just for interest that was published in Lung Cancer in 2019, which was a multi-center retrospective review of time to first appointment, time to first outpatient appointment, which was about 26 days. But the reason I've included it is it just shows that if the upfront cytology is negative, the median time to diagnosis was 30 days compared to 13 days in diagnostic cases. And so I did this as a reflex pleural practice in general, where if you're not diagnostic up front, you can get quite delayed in the eventual diagnosis and management of patients. All right. All right, so this is just a table that looks at outcomes at 12 months follow-up. Just to point out that we didn't have a lot of complications from our treatment group. There were a few patients that had drainage-related pain, so 3 out of 16 of our patients, which is the rationale for admitting our patients for 24 hours to 48 hours post-procedure. But 11 patients had no complication. No patient required repeat pleural procedures in the follow-up period, so that's for 12 months afterwards, which I think is a strength of this kind of process. Our patients had a variety of different management strategies. Some had chemotherapy, immunotherapy, some went straight to palliative care. It was really driven by patient and functional status. 9 of our patients had their IPC removed. The mean time to removal was 55.8 days, which was usually the time of autopleurodesis. So the limitations of this study, there are many. It's a retrospective review, which really just looks at the amalgamation of evidence-based procedures. We did not protocolize our enrolment, which means that we took really highly selected patients that we thought would benefit from this diagnostic and therapeutic approach. So there's a huge selection bias, which is going to limit the generalizability of this kind of data. And obviously we're dealing with a relatively small sample size, but that's the nature of a retrospective review. And we also didn't have all-cause readmission captured in this. And so in terms of my interpretation, basically we're showing that the combination of these procedures is feasible in a high pre-procedural probability for malignant effusion. We didn't get any unexpected safety signals. The time to diagnosis was short, so achieving a tissue diagnosis was short, and no patient, with the exception of drain removal, required a repeat pleural procedure during the follow-up period of over 12 months. And really this forms the foundation for future prospective trials to look at a combined approach and an adjustment to the diagnostic and therapeutic algorithm in future. So thank you very much for listening. Any questions?
That's great. Thanks, Michael. It's really interesting, and it's great to see these kind of studies getting published as well. And it's lovely for us to hear about your work that you're doing. I think it's obviously really excellent, especially for patients with mesothelioma who, cytology is often negative. Would you have any qualms about subjecting lots of people, if mesothelioma wasn't as common, to a pleural biopsy if you thought the cytology is more likely to be positive, or do you still think that accelerating the diagnostic pathway is worth it?
That's a good question. I think, certainly it's beneficial in as you've pointed out, in a mesothelioma-rich group. I don't think I think you have to be patient selective, and it's patient dependent. Lots of our patients are eager for diagnosis and management so that they can carry on living their lives. And I think if you've got a really large effusion that's likely to build up quickly, it's going to take time to get them onto definitive treatment anyway. And so, certainly we put a lot of IPCs in here and we have really good success in all kinds of malignancy. But certainly, this trial was biased towards mesothelioma, and so it would be interesting to expand it more broadly.
Which is happening, right? There's a prospective trial.
That'll be the intention. Okay. Haven't got it off the ground yet, but that's the idea.
Yeah. Sonia,
I was interested a little bit. Yeah, I had a question about because I know it's quite a small sample, 16 from the 200 or so that you had. Was part of that to do with seeing the pleural thickening to allow ultrasound biopsy, or because mesothelioma, I gather the pleural will be more diffusely thickened versus maybe a adeno where we don't really often see the CT or ultrasound thickening. Was that part of the reason that the number was much smaller in terms of how you select it? Was it the radiology?
I think it was a combination of factors. I think part of it was, again, that we didn't control the enrolment criteria. And so we certainly missed a number of patients that come in with malignant pleural effusions, generally speaking. Certainly in patients that had significant pleural thickening, either on the ultrasound, which we're getting fairly comfortable detecting, or on the radiology, we tried to encourage this kind of technique. So I think it was a combination of factors. I don't think we deliberately excluded patients who only had minimal thickening or anything like that.
I think just from my own perspective, I sometimes find it hard to see the parietal pleural thickening as on ultrasound. And so is it more and more experience in the procedure that you sort of see it more clearly?
Yeah, the kind of patients that we were looking to select for this type of procedure had more than a centimetre of pleural thickening or had clear evidence of nodularity. We're fairly comfortable detecting mild to moderate pleural thickening under ultrasound, but we're really sort of aiming for those patients that have significant thickening and are likely to get a recurrence of their effusion and are really likely to benefit from doing everything all at once. And patients with only moderate or mild pleural thickening, we were happy to watch or to sit on.
Okay, well, I mean, I think it's a really excellent stepping stone to accelerating diagnostics for patients who, really need a rapid diagnosis, and reducing the number of procedures and hospital days is really valuable to them.
Absolutely.
With that, I think we'll bring this to a close, Sonia, if you're happy. So we'll just thank Thierry, who's doing the recording, and Kathy, who helped us with a lot of the organizing, and to our speakers, Michael and Arash, and my co-chair, Sonia. It's been hopefully an excellent educational meeting, and we're going to be running more of these going forward.
Thank you very much. Pleasure to be here.